So, we've talked a little bit about why. Now, let's actually define what population health is. Population health is a combination of a few things. It's absolutely an aspiration. I think this is the part that resonates most effectively with clinicians. Population health managers seek to optimize health, engagement, quality of care, experience, outcomes, and cost for individuals over time. This is, in some ways, the easy part of it from a mission standpoint. It's why most people who work in healthcare worked in healthcare to begin with. But, unfortunately, as we've talked about previously, every system is perfectly designed to get the results it gets. The system around healthcare has not been designed to support this aspiration. Which is why population health is also a business model. Population health managers assume total clinical and health-related financial accountability for a population, and then they seek to create, deliver, and be rewarded on this value. So the example I gave around CareMore is a perfect example of this. They built a business model that rewarded them for better outcomes. For a traditional hospital system, if a hospital system invested in those same resources, spent thousands of dollars to prevent falls, to prevent diabetic amputations, to prevent heart failure admissions, they would be spending thousands of dollars per patient only for the privilege of losing more money on the fee-for-service side, because right now hospitals are paid for the number of sick patients that they care for, and if they keep them healthy, that reduces revenue. So the current business model is antithetical to population health, the fee-for-service business model. So population health really is a business model. And this is important to note as we think about some of the interventions for population health, because it's not just enough to say we're improving the health of various populations. We actually need to wrap a business model around that so that that change can be sustained, so that it's not done just out of philanthropy or out of community mission, but so that it's done in a way that self-fulfills and allows additional investments to continually improving the population health management model for a healthcare delivery organization. And third, population health really is a culture and a mindset. Population health managers who are effective are relentlessly person-centric. I'm intentionally not using the word patient-centered because people don't think of themselves as patients. They think of themselves as people who want to live their lives, and they actually don't like when they have to be patients. So population health managers are really thinking about that person end to end across all their interactions with the healthcare system, but also through the rest of their life that might impact their health. And tying the business model and the aspiration together, the idea for a population health manager is that no one wins unless the individual, a person, wins on value. Now, that sounds great in theory, but in practice, this is a very challenging transformation for a health system to undertake, and that's what we're going to spend the rest of the session going through. So for a health system, especially a hospital system, where they start in the fee-for-service world is kind of at the bottom left of this chart. The financial model is straight fee-for-service. They're paid for every click, paid for every encounter, and the clinical model is the one that is designed to support that. It focuses on patient throughput. It focuses on getting patients out the door as quickly as possible. It focuses on, unfortunately, not necessarily investing in things that keep patients healthy, because again, those are investments with no ROI. Now, that business model in the bottom left is a business model that makes sense. It's not a good business model for patient care, but it's a business model that's internally consistent. On the other end of the spectrum, in the upper right corner here, with true clinical transformation that is like the CareMore model or the IORA model or the South Central Foundation model, where all the investments are made in keeping a population healthy, and where the financial model on the vertical axis has shifted such that the provider is responsible for total cost of care, that model works. That's, as an example, the Kaiser model. Not to say that everything's perfect in the Kaiser model. It certainly isn't. No organization is perfect and everybody has ways to improve. But the Kaiser business model is internally consistent, where every aspect of care delivery is a cost, the revenue is the payment on the total population, and all the investments made to keep patients healthy are rewarded through higher ROI. So if the two endpoints of this are internally consistent business models, what about the middle? Well, the middle is challenging because you can't halfway invest in a transformed clinical model, halfway move towards risk, and assume that it will work out. So we'll get into some of the details of that and what's necessary to navigate this transformation. But it's important to think about the clinical transformation and the financial transformation really being in lockstep as an organization traverses this path. So on the financial transformation, a product and contracting strategy is necessary for a delivery organization to change how it's paid. And there are two aspects to this. One is getting paid for value. In getting paid for value, the idea here is changing contracts to align incentives around managing total cost of care. This can happen across different market segments. In the commercial population, it's commercial shared savings and risk contracts. Bundled payments do this by aligning incentives around a total episode. In Medicare, there's the Medicare Shared Savings Program. There are shared savings and risk programs with Medicare Advantage carriers. There are bundled payments here as well, and in Medicaid similarly. But there's a second aspect to this, using this value to actually lock in lives, to capture market share. So this is building products around the delivery system, direct-to-employer bundles, where there's a center of excellence built around a system that is taking risk for a particular episode of care. Individual and group insurance products, whether it's a health system launching its own insurance plan, whether it's partnering with other insurance plans to create narrow network products, kind of the next wave of HMO-style products built around a delivery system. This can exist in the commercial segment, in the Medicare segment for special needs plans, in managed Medicaid for duals. So think about these two different areas, getting paid for value, shifting the incentives, and then using that value to actually lock in market share as you go forward. So in terms of getting paid for value, this is a slide from Health Affairs that categorizes different types of alternative payment models. So in the fee-for-service world, we're in kind of category 1 here. The provider is paid for every service they deliver with no link to quality and value. In category 2, there's some sort of link to quality and value. So this might be some foundational payments for infrastructure, care management fees, paying for reporting data. So telling the provider, well, if you report your quality data in a couple of key areas, then we'll pay you a little bit extra. Rewarding performance. If we improve the percentage of the diabetic patients who we care for, whose hemoglobin A1C is under 8, we get a little bonus. But the underlying payment is still fee-for-service. Or rewards and penalties for performance at times. The carrot and the stick. Category 3 is saying, well, let's take that a step further. Let's introduce some responsibility for total cost of care. And we'll get into the details of how exactly that works. But the idea here is the provider is still getting paid fee-for-service, but has some responsibility for the overall total cost and quality of care for a population. And then category 4 is a true population-based payment. This could be a condition-specific payment, a certain payment for all patients with heart failure, all patients with cancer, or it could be comprehensive. Think about that as the provider taking on the model that is currently the insurance company's business model. So let's dig into that 4th category as a way to more effectively define both the 4th category and the 3rd category in terms of having some responsibility for total cost of care. In today's financial model, in the fee-for-service model, the health plan gets the revenue, the premium, so think of that as $5,000 per year for a commercial patient. That's broken down into a variety of different components. There are payments to the hospital, payments to the physician, post-acute providers, prescription drug, other types of providers. Then there's some administrative amount, and then the health plan retains some profit. And these bars are roughly to scale. The sum of the hospital, physician, post-acute, prescription drug, and other is what we were talking about before of the medical loss ratio. So typically that ends up being somewhere between 80 to 90% of total premium is used to pay for medical costs. The health plan makes more profit if they gain more membership, if there are more patients where they get paid the $5,000, if they reduce their administrative costs, so the admin goes down, the profit goes up, if they pay less to any of the providers. So if the unit cost is lower, then their profit grows because the medical loss ratio drops, or if they reduce utilization through whatever means. In the fee-for-service model, the hospital gets its revenue. It's about 34% of total healthcare costs. So of that $5,000, think of 34% going out in fees to hospitals per encounter. The hospital makes more money if they get higher rates, have more admissions, or if they improve the efficiency of underlying costs. Physician groups, similarly, they're responsible for about 27% of healthcare revenue or healthcare costs from the payer standpoint. They also make more money if they get higher rates, if they see more patients or improve their efficiency. The problem here is that the profit drivers for the health plan and the profit drivers for the providers are in direct opposition. It's a zero-sum game. The payer makes more money if they pay less. The providers make more money if they get paid more. Payer makes more money if they reduce utilization. Providers make more money if they see more patients, irrespective of whether that care is necessary or not. In the population health profit model, the health plan still gets the premium, and this is, again, the category 4 sort of model where the provider has full responsibility for total cost of care. The health plan still maintains some administrative functions, billing, eligibility, enrollment, sales and marketing, those sorts of things. They have some profit, but they actually pay all of the healthcare costs directly to the provider. Then the provider, in this case a hospital system, is responsible for managing all of that cost. So every service delivered to patients for whom the provider is paid this way is actually a cost. If the patient needs to see a physician, that comes out of the initial medical cost payment that's made to the provider. If the patient needs a hospitalization, that comes out of the revenue as well. So there's no additional revenue for each encounter. As a matter of fact, if we can avoid unnecessary encounters by reducing utilization of outside spend in areas like post-acute, making sure patients go home with home care instead of to a skilled nursing facility, reducing the use of expensive prescription drugs, or reducing utilization of internal spend, hospital utilization, unnecessary specialist visits, while removing capacity, because that's the underlying cost structure, then the population health provider can generate a profit in a risk model. So this quite literally is taking what used to be a revenue and turning it into a cost, which is a more systemic change than any other industry has undergone at any time in history, actually. So what the healthcare industry is trying to do in making this shift is total systematic transformation. But you can't do that all overnight. So this is an example from a delivery system that is actually, and these are real contracts and real patient lives and real growth in the physician base for a health system as they move towards risk. And in 2014, their model was almost entirely fee-for-service for the patients who they deliver primary care to. And right now in 2017, most of the population is in some sort of shared savings, that kind of category 3 model, or in full risk, category 4. And by 2019, even less will be in fee-for-service. When we have a session later on models of contracting and financial models for healthcare risk contracting, you'll get a better sense of why some of that population remains in fee-for-service even as the system transforms. But this falls into the category of the things that are complicated for a system to navigate as they make the transition due to the way the overall healthcare ecosystem is architected. But it's not enough to just get paid for risk. As you saw on that prior page, that health system was assuming some growth in the number of patients that they were responsible for. So how does a healthcare delivery organization commercialize this value? If an organization achieves the outcomes that we talked about with a CareMore or a South Central or an Iora, then what do they do to actually commercialize that and bring in more patients because they're delivering better value on a population basis? There are a few examples here. One could be worksite solutions sold directly to employers. 60% of commercially insured patients are actually paid for by the employer. It's the employer functions as the insurer. The insurance company just processes the claims. So over 30% of Fortune 500 companies now have a worksite clinic or worksite practice in one or more locations that they operate in across the country. So health systems could be providing these worksite solutions in order to manage care more effectively at the point of care and drive the downstream utilization of those patients into the system to offset the underlying fixed costs that the healthcare system has as it reduces the cost per patient. Telemedicine solutions are another example. Similarly, could be offered at the worksite, could be offered through employers or through other channels to create greater patient affinity to health systems to provide care in a lower cost manner. Bundled payments and centers of excellence are a way that some healthcare delivery organizations are commercializing their value. If they've re-architected the care delivery process around something like a joint replacement and know that they can reliably provide it for a certain cost because they've gotten the readmission rate down, because they know how many patients are going home instead of to skilled nursing, because they've standardized the implants that they use, they can offer that as a price out to the market, and employers will steer patients because of this. And this is happening across the country right now. And then insurance products. So if instead of delivering the care for the $5,000, if a health system is able to manage the care more effectively and deliver it for $4,500, they could retain some profit on that, or they could use that to price a product out to the market at a lower rate to employers or individuals in order to capture people earlier on at point of benefit election rather than at point of care delivery. So that's the financial side of it. What about the clinical access? And because I'm not a clinician, though many of the sessions after this will be taught by clinicians who I work with, I'll use a non-clinical example to define what I mean by clinical transformation. I think transformation is one of the most overused words in healthcare right now. And as a matter of fact, I've probably used it several times in this talk already. But when we talk about transformation, what I want to highlight is what true transformation is. So, as an example, imagine it's 1850 and you're running a shipping company, and you take goods from New York to London, and it takes 15 days to transport those goods. And then a customer comes to you and says, I need my things from New York to London in 10 days. What do? You build a faster boat. So then if a customer comes to you and says, well, 10 days is too long, I need to get my materials from New York to London in 6 days. What do? You build a faster boat. What if a customer comes to you and says, 6 days? How about 6 hours? You say, I'm not in the boats game, I'm in the planes game. So that's transformation. Faster boats is improvement, but fundamentally changing the paradigm is transformation. So how does that apply to a clinical setting? What health systems need to do to succeed in population health is both improvement and transformation. So improvement is consistent quality, standards of care, a focus on an improvement mentality. This is kind of mile wide, inch deep, getting deeper every day. So if you think about it from a primary care setting, this would be starting to look at the diabetic patients who are in control or out of control. Starting to think about not just the patient who's right in front of you, but thinking about the broader population. Starting to share more data and information. Starting to embed care management so that we can help patients navigate more effectively. Maybe getting patients follow-up visits after a hospitalization more effectively. What would transformation be? Well, that's total clean sheet of paper redesign. A model that's purpose-built for outcomes. Again, think about every system is perfectly designed to get the results it gets. Well, a primary care practice, for example, is perfectly designed for fee-for-service medicine. There's a focus on efficiency, on getting patients out as quickly as possible. And in the fee-for-service model, every time a physician hires staff to spend time with the patients on something related to health management, that's investment that has no ROI. Every time they spend an extra 10 minutes with the patient making sure that they understand something about their clinical condition or the social determinants related to it, that's an investment of their time that's actually actively in opposition to their economic self-interest, yet they do it anyway because it's the right thing to do. So in a transformed model, what we would have is every role, every responsibility, every policy, every procedure being different from the ground up. So an example would be in the patient-centered medical home model, which is an example of improvement. One of the ideas is adding a morning huddle so that the clinicians and the non-clinical staff get together in the morning and look at the patients who are coming in so that they aren't thinking just about Mrs. Smith, who's at 9 a.m., but also the other 22 patients who come after her and what they're going to do for them. But that's not really population management. That's just slightly more effective pre-planning for care. That's improvement. In a transformed model, you wouldn't think about the 23 patients coming in today. You'd think about the 2,300 who aren't coming in today and who might need to be. Who was in the hospital 2 days ago, and maybe we should get them, call them. Or if you need to send a medical assistant to go pick them up because they don't have good transportation, doing that. So changing roles, responsibilities, all of the workflow, the space design, how we think about engaging patients to really be purpose-built for the outcomes of population health. That's the type of model that an organization like an Iora or a CareMore or South Central has implemented. But that's very challenging. Building a plane, to my point before about there isn't an innovation problem in healthcare, there's a diffusion problem. Building a plane is reasonable. That's something that there are examples of. Changing a boat into a plane while it's moving is much more challenging. Not to mention changing hundreds of boats into hundreds of planes, transforming an armada into an air force while in flight is particularly challenging, and nobody has really solved that. But what organizations are doing that are trying to drive towards a population health model is experimenting with transformation, focusing on improvement, learning from the transformation so that they can more effectively transform all of the practices at scale as they move forward. And then, as if that's not complicated enough, this actually needs to be done across different care models. The plane model for a young, healthy 30-year-old who really just wants convenience and access might be built around telemedicine, might be built around appropriate use of allied health professionals, might be built around 24/7 access. The plane model for a frail elder patient is going to be completely different. There might be chronic disease management, embedded palliative care, embedded programs for patients who have multiple chronic conditions, and so on. So the transformed model for population health necessarily means thinking about the subpopulations. Each individual person, how they roll up into archetypes or segments that have certain needs, and then purpose designing clinical models for those populations. So instead of specialization necessarily by body part or specialization by organ system, this is specialization by thinking about different types of populations, obviously leveraging the specialization that we have in the healthcare industry already, but it adds an additional dimension to how we think about managing the overall health of a population. And then, of course, to be successful in all of this, we need more data. We need information. In a later section of this course, the experts from the Mount Sinai Health System on IT enablement, infrastructure, and analytics will dig into the details of the IT enablement needed in a complex large health system to actually navigate this change. But at a high level, if you think about the data that we have right now, all of these examples down the left-hand side of the page, all of healthcare data was originally designed for payment. EMRs were originally billing tools. And then because payers required clinical documentation to pay the bills, they became clinical documentation tools. Healthcare claims data is just that. It's administrative claims data on payments made. But if we take all of this data together, the EMR data, referrals, claims, lab data, prescription fill data, health risk assessments, patient-reported outcomes, remote monitoring, and anything else, and actually combine it all in an interoperable manner, supplement it with benchmark data so that we know if the admits per 1,000 are 250 for a certain population, that compared to the benchmark, that's 10% too high. Or if 20% of our patients with diabetes have a hemoglobin A1C over 9, the benchmark is actually 15%, and so we should be able to do better. Combining it with the benchmark data, integrating it all, having common definitions, which is harder than it sounds because the way any one of those systems on the left defines a patient with diabetes is different than how another one might. Use that to drive risk stratification, identifying who are the high-risk patients, who does need to be intervened on, identifying who falls into various segments for which types of clinical models, doing predictive modeling to say who is likely to be the next admission, who should we intervene with before their condition deteriorates to that point, finding gaps in care, who still needs a certain screening, who needs a referral to a certain type of specialist to make sure that their care is being managed more effectively, and then embedding all of that into workflow. And then using that common data infrastructure with all different audiences. Patients and caregivers will want to see things through a patient portal. They might have other applications or mobile alerts that they want to receive. They should also be able to have two-way messaging through the remote monitoring equipment that ties into all of this data. Physicians want to be able to see how this flows through in their workflow. This should be able to drive their workflow, which is largely governed by EMRs today, having alerts as appropriate, having performance dashboards that allow them to drill down to the patient level and understand where the gaps are. Care managers will need this information to support their care management workflow platform. Customer service should be thinking about this in their patient CRMs. There are many missed opportunities here where there might be a care manager who's trying to reach out to a patient to get their annual foot exam for their diabetes scheduled, when in fact they can't get a hold of them, but that patient is calling the billing department about a question they have there. If we had an integrated platform, if health systems had integrated platforms that allowed this, that billing manager could see the alert and say, well, while I have you on the phone, I'd like to transfer you to Jane, your diabetes educator, who wanted to get you in for a follow-up visit. Management would need this data for standard reporting packages, custom analytics tools, performance dashboards, and then payers will need this information so that they can appropriately risk adjust the payments, so that they can look at quality reporting across whatever platforms are used. So this is a perfect end state, and again, the experts on this will share a lot of context around why this is really hard to do, what the first steps are, but at least wanted to share how an ideal end state might support the sorts of clinical and financial transformations that we've talked about. And then, of course, there's also compensation and alignment. We'll have an entire section on physician alignment models, physician empowerment, physician engagement. But at a high level, figuring out how to pay differently for value is very important, and it can't just be done at the organizational level. If the overall healthcare delivery organization is paid for managing total cost of care, but if the individual providers are still paid on a per-click basis, then there are misaligned incentives between the organization and the physicians. And this is a drastic transformation, especially for primary care. In the fee-for-service model, they're paid for each visit, which means the incentive is to see the patient as quickly as possible and get on to the next one. In a total value-based model, the primary care physician, if you think about the right-hand side of this page, would be paid for productivity more built around panel size. How many patients are they responsible for? Risk-adjusted panel size, actually. The satisfaction for those patients, quality, and efficiency of care. How effective is the primary care team at managing the total cost of care for that population? But, as we talked about in terms of the contract transition, this takes time. The clinical transition takes time. So the compensation model needs to shift over time as well. And so this is just one example, again, from one healthcare delivery organization, of how they shifted from a traditional model to a future state model, and they're in year 3 of this transition right now. And then if we think about engaging consumers differently, what can we do there to be more effective? Engaging consumers in their healthcare. And just this is one example, which is access. If you think about what a patient wants, they don't want to they don't define their need as a visit with their physician. They define their need as getting care, which could be achieved through many different means. It could be guided self-care, educational content informed by appropriate medical guidance. It could be asynchronous e-primary care, so this would be emailing or texting or secure messaging with clinicians. It could be synchronous teleprimary care, Where clinically appropriate, this could be covered through a phone visit or a video visit. It could be convenience care, retail or convenience care clinics run by nurse practitioners or physician assistants. If the acuity is higher, maybe it needs an in-person primary care visit with your physician. It could be specialty care immediately, because the acuity might be such that a specialist is who is needed to deal with the clinical nature of the patient's need. Could be an urgent care setting, if there's some sort of minor trauma and imaging is needed or sutures are needed, maybe urgent care is the appropriate place, or it could be the emergency room. And there are plenty of other examples in between. But when a patient has needs and needs to access care, one of the goals in a population health model is to meet that access need in the most efficient and clinically efficacious manner possible that aligns with the consumer's preference. So you could imagine a consumer access model where the patient can interact with the system through phone, mobile device, their computer, whatever external platforms or anything else, be triaged based on their needs, both clinically and their personal needs or their lifestyle needs or their social needs, into either instant access to some of the low acuity elements here, a easy to access central appointing model for scheduled visits with primary care, convenience care, specialty care, urgent care, or pre-notification for walk-in, if that's appropriate. But really re-architecting the system to support engaging the consumer in the way they want to be engaged, to getting care in the way that, again, is most clinically efficacious and efficient at the same time. Those are the sorts of innovations that would be needed to really reduce the cost of delivering services to patients in a population health model as it relates to consumer engagement. And again, this is just one example. We'll go into additional examples further on in the course. Now, all of this, if it sounds complicated across various elements of the transformation, it is. It's also complicated from a financial standpoint. And this page is intentionally complicated to show you, and again, this is an example from a specific healthcare delivery system that has about $6 billion in revenue and currently operates at a 5% operating profit, as they look at navigating this transformation to a full risk model. And so there are some reimbursement cuts, thinking back to payer-driven reimbursement cuts at the fee-for-service level, some pretty significant reduction in volume as they improve population health. The revenue comes down, they can take out costs aligned with that as well. There's the shared savings risk payments that come back. Notably, those don't make up for all of the volume reductions, because if they did, then there wouldn't be any money returned to the sustainability of the healthcare system. It would all just be keeping everybody whole, which doesn't actually solve the problem that population health is trying to solve. There could be some sort of share capture through some of the commercialization initiatives, through reducing leakage or outmigration, through capturing more attributed lives. There needs to be some cost efficiency of just driving additional administrative efficiency and clinical efficiencies. And then new business models, convenience care, new access models like we talked about, telehealth, urgent care, those could drive some revenue. But this future baseline that this system was projecting involves a similar operating profit to the old model with a lower revenue base and a lower cost base. And most notably, they identified that they really need to reduce underlying costs and remove capacity, take out beds, move things to an ambulatory setting, reduce overuse of specialty resources in order to be sustainable in a future model. Now, again, this is one example for one system. For any system that goes through this, it would look different. For a physician-led organization that doesn't own hospitals, it would be different as well. But when we're turning upside down the overall economics of the healthcare system and then starting to align initiatives to optimizing in the future model, it necessarily means that there are a lot of complex financial trade-offs in the period in between to make it successful on the other end. So, to conclude this introduction, why population health? Because we ought to, for Fred, because we must, for economic sustainability, and because we can, because others have done it. What is population health? Well, it's an aspiration, it's a culture and a mindset, but it's tying those two together into a sustainable business model that allows continued investment in improving the population health model over time. And then how, through a simultaneous and very deliberate transformation over a multi-year period of the financial model, the clinical model, the incentive model, the infrastructure, and the underlying cost structure, all in sync with one another. So as we go through the remainder of this course, we'll dig into the financial, the clinical, the incentive, the infrastructure model, and the cost structure, and share through a mix of theoretical constructs and real case studies of organizations that have done some of this, both Mount Sinai and outside, of how an organization navigates this change, how an organization balances the old fee-for-service model with the new population health model as the transition is made, what's necessary for success, what some of the pitfalls are, and what some of the areas are in which to focus that can drive greater value more immediately. Thank you, and looking forward to working with you through the rest of this course on all of this.